Hi, let's see if I can try to wrap up uh, this section of the talk about therapeutic factors and group psychotherapy, and there will be more about this in the experiential class. But I'll do this. I think I'll talk about four different ideas here. One is therapeutic factors from the perspective of attachment, which I think will be interesting to many students. I'll talk about it from the more kind of classic interpersonal group psychotherapy model that I think is commonly practiced. I'll talk about it from a cognitive behavioral view that many of you will probably do on your practicum internship and throughout your careers. And then maybe I'll add a few extra ones that seem vital, that are very strongly supported in the literature from the contemporary framework of the literature that's happening now. So let's start with attachment perspectives. So I'm working here mainly from the model of Sherry Maramash and then some of the people she worked with like Markin and Spiegel. But they would talk about, I think, these 7 factors mainly around reworking attachment in group psychotherapy, which is a big piece of, I think, working with and expanding one's personality, long-term, dynamic, intrapsychic change. So the first is empathetic attunement. This refers to resonating with a group member's experience, but ideally not just the surface emotions, but also underlying emotions, defensively hidden feelings. I think my favorite example of this, which I may have given, was early in my own analysis. I was talking about someone who I felt had hurt me really bad and associating about how I would treat them when I saw them next. And my analyst said, "Oh, Francis, you want revenge." And this was highly empathetically attuned. That is what I was having fantasies about at that moment. So I think this will not always look pretty and may even look confusing to other group members. But I think as a group leader, often these will be the types of interpretations that you'll see group leaders do, is taking it to the next level down in feeling through empathetic attunement that feels correct for the group member, but may not look correct to the members on the outside. So say I have a group member who I can has shared a lot, isn't getting attuned to, or no one's joining their universality boat. I might turn and say, I wonder if you wish you could disappear right now. This would be kind of a empathetic attunement of shame, potentially. And then I might even follow it up, see what happens from there with something like, do you wonder if you're feeling the right level of annoyance at your other group members for not saying anything to you? So this would be potentially attuning to the unconscious, not tasteful idea of annoyance or frustrations with others, which some group members may not hear, may not be able to tolerate. So, I mean, ideally, as the leader, it's your job to empathetically attune with everyone to the best of your ability. And sometimes that may be challenging. I can think of a member in my group now who, for whatever reason, I have a harder time feeling in some way. But I feel lucky in that group that although things are changing, I often felt this person had a very deeply and to some degree severe anxious ambivalent attachment, which all my interventions for the first 3 years didn't do much to help this member recognize this and move forward, although recently he's kind of hinting at the noise in his mind and the voices in his mind, and I think we're getting somewhere with this. But I was trying to empathetically attune often at a deeper level of my interpretation of his intrapsychic process. But I think as he was speaking earlier, the other group members, luckily, and I feel very thankful for this, were able to empathetically attune to him, often on a content level. It might be as simple as, yes, it's very difficult to know what kind of cryptocurrency to invest in. Or, yes, I can see why this would be very difficult as someone who likes to have a lot of free time to be asked to work 60 hours before the rollout of this product in some way. So, being mirrored is essential, I think, to rework attachment in group. And this would be the first therapeutic factor from this attachment perspective. The second would be facilitating mentalization. So you can do this through the group process and feedback. So mentalization is somewhat taking a meta view. I'm thinking many of you are familiar with it, very popular the last couple of decades in Western psychology. People have mixed feelings about whether this is very Buddhist or not very Buddhist. But these processes are somewhat similar to empathy. It's efforts to try to truly understand another's experience. It's rather than just relying on one's assumptions or projections. So it's kind of digging in, deconstructing, questioning. A question might be, do I have it right? Am I understanding this right? And I would constantly kind of go back and ask members if they're being understood, who understands them, who can get in their boat, help row their boat. So this is somehow getting some kind of cognitive languaging around one's experience that a group member can help people find the more precise way of describing their experience so it gets communicated. I think the third idea of attachment therapeutic process would be this exploration or identification of transference, or what Sullivan might call paratoxic distortion. I mean, these processes, you're looking deeply at one's internal working models, object representations, from a cognitive view, maybe people's cognitive schemas or social cognitive templates, or internalized representational world, depending on your theoretical orientation. You'll hear this talked about in different ways. So the identification and interpretation of such distortion provided to each group member will provide an opportunity, I think, to re-examine and reappraise their current kind of internalized social perspectives. The process is very salient in groups kind of guided by these psychodynamic theories, and interpretation and analysis and challenge of this will be common ways of doing this. I think the common way you might hear this done is a group member will say, Francis doesn't care about me. And I might say, oh, what has given you the idea that I don't care about you? This is used in both kind of psychodynamic therapy and this transference analysis, or we're looking at the facts would be often done in like cognitive types of therapy. And they will say, oh, you didn't say hi the other day. And I'll say, okay, I don't remember hearing you. And you're just denying it. You don't like me. And then I'll say, what do other group members think? And they may point out times when I've been empathetically attuned, asked them for their views, celebrated a success with them, tried to problem solve a kind of crisis situation with them. And in some way this is challenging what could be potentially a transference reaction. And then the idea in attachment in this theory or psychodynamic theory is that when we start questioning our own opinions about other people and start exploring our own transference, we're open to seeing people in other ways and not being stuck in this repetition that other people are this way, often like our experience with our earliest attachment figures. So the fourth idea here I'm going to share about attachment-based therapeutic processes in group psychotherapy would be emotional or cognitive insight. Now there's different levels of this, and it might be perceived differently by different people. But you kind of want to help people understand what's happening internally. Someone will share a difficult story in group, and some will be like, well, at least it's not snowing outside, or at least you didn't get hit by a car, or at least your arms still work if someone is having lower back sciatica pain in some way. So I think you're trying to ask that member who said such a thing, what is going on for them? What is their feeling? Are they overwhelmed by the pain of the other member? Is there some way that making light of things was their coping mechanisms or a coping mechanism in the family? You're kind of looking at these kind of deep relational childhood patterns that are kind of reoccurring in the moment. If someone expresses some annoyance, do they get quiet? Is that the time when they have to go to the bathroom in group? So you're gaining some insight, often in languaging. Oh, when someone is annoyed or in the range of anger, you feel like you must withdraw or run away. So it's kind of looking and studying these kind of relational patterns and bringing this out. Is this a possibility in group and that people can explore themselves? The fifth one is corrective emotional experience. So what is happening that is different than has happened in the past that's making a relational attachment impact for that group member? Potentially, is someone talking and the group members are listening and paying attention and feeding back and asking questions? Is this kind of a corrective experience that they didn't have when they were kind of dismissed or ignored or neglected in some kind of way as a younger person? So the sixth one is internalization. So often this is considered a robust therapeutic factors, as it kind of is the idea that you're developing new representations. You're internalizing new ideas about yourself and our others. Your old kind of social cognitive templates, your relational templates, your object representations are in some way getting challenged and over time replaced by potentially more functional, more accurate representations of how other people see you and how you see other people. I think you do this in two ways. I think one is in the here and now, that you have members talking about their responses to one another, their feelings they're having both towards each other and inside themselves. So a classic example of this is someone will say something and another member will be silent, and I may see the member who spoke staring or looking at this other member, and I'll say, oh, what do you think Jane may be thinking right now? Jane thinks I'm stupid. This would be something. Then we can challenge this. Jane, I noticed you were quiet, and I noticed John looking at you. Would you be willing to share what was going on for you when you heard John talk? And Mary might say, I felt very sad that I've often felt stupid myself, or that was an early message that I got, or this just happened to me at work or in one of my relationships in some way. So in some way, this internalization of being stupid is getting challenged and potentially, maybe initially changed to, I might often think I'm stupid, to the idea that perhaps I say stupid things sometimes, perhaps I don't get everything, or perhaps that I'm very competent to live a functional life in some way. So we're internalizing and changing the voices, the feedback from the group, to have a new representation of ourselves and of others. And then the last one they feel from an attachment perspective is the most important group psychotherapy factor generally considered is cohesion. That if you can help people with challenged attachments to kind of feel part of something, that their tendency towards attachment behaviors of withdrawal, avoidance, deep confusion, depending on the attachment style here, can kind of get reworked and they can be part of something. I think it's important for a group therapist to kind of continually work on cohesion with each member, and that may have a slightly different flavor that's needed for each person to bring forth this kind of sense of belonging in part of something. Somebody may need to talk about something mundane, and is there a way that we can help the group to tolerate, accept, work with this idea of everyone needs something different to feel connected, and be willing to be adaptive to help people have these new experiences of connection. I think from this view, some of these more therapeutic processes of feedback, confrontation, come secondary to reworking these kind of early attachment wounds in some way. So I think some of this comes from, as everything in group psychotherapy, comes from some of these interpersonal schools of thought. So Dennis Kivlingen, who I talked about earlier about therapeutic processes and his model, kind of gives 3 ideas of what he feels are most essential for making change in group psychotherapy. So he feels, as Yalom would, and many group leaders do at various schools, bringing the discussion into the here and now. This refers to an effort of moving from content about stories and their there and then experience into what's happening here and now. You are telling the story. What is your hope of the emotional impact on other members? What are you hoping to gain from telling the story with us in this moment now? When people say, oh, it reminds me of a time, bop, 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 that this was similar to me. In every story, there's a feeling. In everything we're saying, there's a feeling towards other group members. Why are you telling that story now? What is it that you want to say directly in this moment to the other group member? So here and now is often a representation of the internal world of people, and I think you can get a lot of benefit from retelling your story, but you have opportunities for kind of new emotionally curative experiences through here and now in the group members. So the second one, I think, is making disclosures, or sometimes they would call this impact disclosures. The people talk about their impact that they're having through other members' expressions, behavior, and group. This is deeply bonding, although not always pretty in some way, but for people to say, when you say this, I feel bored. When you say this, I find you very attractive. When you say this, I feel a lot of sympathy. What are the emotional reactions that people are inducing in other group members? How did they learn to act this way in their interpersonal relationships? Were they aware that these are the common feelings people have towards them? So disclosing about the relationships within group, Kivlingen calls this making impact disclosures, or disclosures about the impact members are having on each other. And this would follow the idea that through making these disclosures would be the next one, which we covered a little bit, a corrective emotional experience. that people can feel like they're being seen, mirrored, understanding their impact, potentially get new information or new emotional experiences from some old ways of being in relationships with one another. So I think these are wonderful ideas. I think you can look at potentially the work of modern analytic groups and Lou Ormont, although they would frame this differently, of these ideas of here and now, sharing how you feel about other people, and kind of corrective emotional experiences that can come out of group. So let's talk a little bit more about the other side of the field here of cognitive behavioral groups. So what are the therapeutic factors that members might try to participate in, group leaders might try to facilitate in a cognitive behavioral group? So I think installation of hope, optimism, problem solving, possibilities, change moving forward, installation of hopefulness. I think I'm pulling these from Beiling's ideas, and as I've said before, one of the wonderments of psychology and the challenges is that every school of thought uses different languaging, and they mean slightly different things. But the second one Beiling talks about in cognitive behavioral groups is a sense of inclusion, which I think could kind of be this ideas of acceptance, sharing the talking time, but that general universality, that people's problems, symptoms, challenges are understood by other people. Now, generally, this can also be done in a CBT group through kind of proper placement of the proper person in the group. We're talking about group fit here. So you wouldn't want to put someone with, say, recurrent suicidal ideation in a group, in a CBT group that mainly focuses on agoraphobia, learning, thinking, and behavioral skills to overcome agoraphobia. But if you can find the proper group composition where people have enough similarities, people can feel included, and then you want to highlight this kind of universality inclusion. So the third thing in CBT groups about a therapeutic factor you might want to think about is a kind of group-based learning. How can you make the psychoeducational material that you're presenting kind of work it into a group where it's interactive? So I think a common way when you do larger groups, say you're doing I would do this when I was doing CBT groups of like 16 people. I might start the group of talking to someone if we're talking about kind of getting feelings of overwhelm and coping with overwhelm. They might talk to each other in a pair about feelings of overwhelm, and then they might talk in a pod of 4 people about this, and then bring it back to the group in some way. And then I think the other way you're kind of thinking about group-based learning is somewhat kind of bringing it into the here and now, as we saw in these other models. We're talking about this example of overwhelm. We might ask if people are overwhelmed now. Why are they overwhelmed? Why are they not overwhelmed? What would overwhelm them? And then kind of bringing this up as a topic of discussion. When anyone's feeling overwhelmed in the future of this group, can they raise their hand and talk to this? So in some way that the group members are teaching each other beyond just the leader giving a lecture in some way. Now this falls very much into the next factor, which is 4, which would be altruism. Members trying to help each other, understand each other, giving feedback to each other. A sense of self-mastery, relational mastery that kind of gets instilled and carries over through helping each other in the group. So although these are CBT groups, you're also looking at this fifth factor of kind of relational patterns. How are people relating with one another that's kind of interfering with the learning of new cognitive behavioral skills, or ways that are helping people learn new skills in another way. So in CBT groups, there's often some kind of in vivo practice. So you might learn a skill, say moderate breathing for anxiety and panic disorders, and then you'll practice it in group. And then someone is having a hard time doing this in the group, and then you see a group member roll their eyes and the person sees that. So you might point that out and say, what was happening for you? Why is this challenging? This isn't helpful to the learning in some way. Where you may have another member say, I also had a hard time kind of doing this intermittent breathing. I either wanted to take short breaths or really deep breaths. It doesn't come natural to me. And then in some way reinforce and thank that member for the positive way of relating that will help the group learn these new cognitive and behavioral skills in some way. The sixth one is kind of identifying difficult or painful emotions. While we want to have hope, we don't want to deny everything that's occurring in the room in the moment. So in the early example, when someone rolled their eyes, what was the example then? What was happening? So that person may have felt not important. They were rolling their eyes, may have been having a projection of someone they knew who was a somaticizer as a secondary kind of gain for getting attention, a way of getting attention. So you want to bring in, this is difficult, I'm bored, I'm angry about this, I wish I didn't have these problems. That in some way, having people be authentic and full, even with the more negative types of feelings, is important in CBT group. Now I want to highlight this. We're in a dynamic, psychodynamic, psychoanalytic type of group. You may stay with someone's difficult emotions for the rest of that group experience, and that would be kind of the client-centered view or the group client-centered view, that what emerges in the group is what the group members need to work on. In a CBT group, working often from a manual, you might explore this for 3 minutes, 5 minutes. If it links up with future pieces of the manual, you might say, we'll get to this more, but you want to at least acknowledge, accurately attune to that experience in some way. And then the last one that Biling talks about is cohesion, and group members feeling part of something, they're working together. Now I think this is, if I wanted to say one other thing here about psychoeducational groups or cognitive behavioral groups, is that in some ways I view these as almost superior to psychodynamic groups, because in addition to kind of mastering the group process of getting everyone engaged, setting a structure, reinforcing the structure, moderating tension levels, there's also a level of kind of expertise around the topic area and the inability to present that expertise around the topic area that's very much needed to be an effective CBT therapist, in addition to moderating the processes. I think I'll end here and talk a little bit about some other ideas that you see discussed in the therapeutic process literature that we may have not covered yet. So I think this idea of safety. So safety is often a difficult topic, and in group people may say they feel unsafe. Now we need to kind of deconstruct this and explore this in that, what does safety mean? Safety, generally I explain to my group members, means that no one is going to hit anyone. I'm not putting anyone who I think is antisocial in my group who's going to stalk or internet troll another person in some way. uh, but that you may get your feelings hurt. You may hear things that you don't want to hear. That despite this, the group leader and members will try to help you feel as if you belong, digest, understand, move through various feeling states, and that you will be welcomed here, included here, and that physical safety is ensured. I have to tell this brief story about physical safety. Early in my career, I was doing a group with people from an officer from the Air Force, an enlisted person from the Army, and they were having disagreements about basically sobriety versus harm reduction models, although they wouldn't frame it this way. And the enlisted person disagreed with the other one, and the officer said, "You call me sir when you speak to me," and stood up, and the other member stood up and said, "We're not in the field anymore, sir. Well, if you want to work this through with me now." And they got right in each other's face, and I wasn't sure what to do. It's not in the Yalom book when I read, "What do you do when two members are about to come to blows with each other?" I stood up and I said, "You sit down, I'm going to throw you both in jail." It's probably not true. I could have thrown them both in jail. But they did listen to me. They did sit down. And then I said, "You can't say anything." And then I think I told some very kind of boring cognitive analysis, psychoeducational, about the research on the different views of sobriety versus harm reductions and in long-term recovery and different personality features that attract different people to each. This was purposeful to kind of reduce the tension level in group when you're engaging people's cerebral cortex as opposed to their limbic system. It can be somewhat soothing. I lowered my voice. I talked slowly. I kind of put them into a unbelievable fugue state of boredom. And then I felt like once the group was re-regulated, we went back to talk about what is allowed and not allowed, safety in group, what are boundary violations that will get someone kicked out of group. So I think constantly kind of quickly when there's a boundary violation, depending on how you run the group of, I had a group member who got up and wanted to hug everyone in the group, and some people didn't want to hug this member. Some people eventually said that they thought this was creepy or even violating that. In some ways say, "Oh, we don't do that in here." Immediately stepping in to reinforce safety is essential, I think. I think the other idea I want to talk about is I would say kind of goes back to one of Freud's final articles, which would be remembering, repeating, and then working through. But this idea of the hope of working through, I think that the idea that through repeating processes, relational processes, miscommunications, reworking them, examining, practicing, that new learning, understanding skills will be internalized in some way. That this isn't, in my view, a kind of linear process all the time. Although there's manualized treatment or progressive treatment modules like system-centered therapy, where first you work with masochism and then sadism, first you work with overstimulation and then withdrawal. But that it doesn't always work this way, as people are unique and no person fits a manual perfectly. But I think it's important for the idea that working through involves pacing, meeting your members at the next step that they can reach at. So in terms of you could give a grand interpretation of someone's personality, but I don't know if that's really helpful towards working through. It's overwhelming. It may feel satisfying to the member that someone's paying attention to them. the research say that people may disassociate when you give such a big interpretation, but in somewhat more slowly, maybe initially accurately attuning, you feel angry, and then maybe the next step might be kind of taking it one level deeper. You didn't have good models of how people worked with anger in your childhood. Well, what were the possibilities then? What are the possibilities now? What would you like to do given these possibilities? That in some way working through isn't, change doesn't happen A to B, but A through Z with many, many micro steps. So I think an appreciation of this and a pacing of work is kind of needed in this. We talked a little bit about CBT, but I want to re-highlight it here. This idea of in vivo practice, whether it's a behavioral group, a cognitive behavioral group, a psychodynamic group, a T group, a humanistic group, that somehow people are practicing new behaviors in the here and now, in the group, that are kind of getting internalized, embedded, reinforced, they're getting feedback on their behavior. That group is a place where we practice how to be people outside of group. I think the fourth one I want to talk about as a therapeutic factor, and I would put this actually in the attachment views in my conceptualization of attachment, although it wasn't there in the Maramash model, would be emotional regulation. That group members are practicing emotional regulation. The group leader is modulating tension levels in group. The focus of one stimulation level is a topic of constant exploration in group. Group leaders are asking about it, noticing it. What's happening for people now? I don't know, I'm daydreaming. It might mean they're disassociating, overwhelmed. I'm bored. What is it that's happening that can help people kind of have these emotional regulation skills of tolerating intimacy, tolerating relationships, continuing to be able to focus? And then I guess the last one I want to talk about, which I think will get more and more in the group literature, is this kind of idea of mindfulness. That a therapeutic process of paying attention on purpose to what one's thinking, feeling, what other people are saying. You're expanding people's awareness to tones of voice, their own somatic experience, the body movements of others in some way. That we're constantly noticing and developing the ability to describe, and we're bringing that into all our groups as a kind of fundamental component of a mindfulness group, regardless whether it's psychoanalytic or dialectical behavior in some way. So let me say a few things. This is a fascinating and very broad topic of therapeutic factors. I like to view it as it's beyond just here and now experiences, but I like to think about it also in terms of it's the underlying conditions that create change in group psychotherapy, such as safety and structure and clear boundaries, making the implicit explicit. No one model of therapeutic factors will work for every group member. Different people will need a different buffet of therapeutic factors to reach their goals and to kind of make their changes. So let's stop there on therapeutic factors. I think I'm going to revisit this throughout the rest of our talks.